Hi, this is Dr. Avinash. Welcome back to this special webinar only for people who enrolled for my ECG courses. I hope you are practicing your ECGs regularly. I'm very happy about the fact that you people are sharing your ECGs on our group and discussing them. So keep doing that. As you do more, you will learn more. Let's continue with this webinar. For this, we definitely need the worksheet, because in this worksheet we have a section for chest x-ray. So let's start with our topic for today. We are having a look at a step-by-step guide to ECG. We are having a look at a step-by-step guide to chest x-ray. Now I'm going to discuss the most easiest method of having a look at the chest x-ray. This is of course not the only method, but as I said in the classes that day, if you follow my method, the chances of you making a mistake reduce drastically. You tend to get the correct answer faster as compared to anybody else. So let's have a look at the steps that you should take while checking out an x-ray. First things first, let's understand the fact that an x-ray is basically a black and white structure. You need to understand what is black, what is white. Black, for all practical purposes, means air. Extreme white refers to metals. Most of the bones are whitish in color. They are not extremely white in color, whereas you get fatty tissue which appears as lightish gray, and the other tissue of your body is somewhere more whiter than the fatty tissue. Step number one is going to be identifying the patient particulars, including the name and the date of birth. As you all might have understood by now, as we age from childhood to adolescent to adulthood to old age, there are a lot of changes that happen in the structure and the tissue of a human being. The bones will become weaker, they will become osteoporotic. So of course, the x-ray representation will also change. So keep that in mind when you're having a look at the x-ray of your patient. Similarly, confirm the fact that the date of the x-ray matches with what the patient is telling you. It should be a recent x-ray. If possible, get the time at which the x-ray was taken. This will help you in follow-up later on. And if the patient has had a history of a similar disorder in past, or has a series of x-rays being taken, it's always good to compare all the x-rays together so that you can make a good informed guess about the progression of the disease that this patient is having. Okay, so check the name, check the date of birth, make sure that the x-ray is a recent one. If you can get the time of x-ray, that would be fantastic. And finally, and very importantly, see to it that you compare this latest x-ray with the patient's previous x-ray to get a complete idea of what the patient is suffering from. Let's start with the most important step that you will do after step number one. Step number two is going to be the mnemonic that I use for this is called as RIPE, R-I-P-E. R stands for rotation. I is for the inspiratory or the expiratory film. P is for projection, and finally E is for exposure. Now I'll give you the details of this eventually. You will be given some examples so that you understand this in a much better manner. But let's start with the first topic here, R, rotation. What does rotation mean? We all know the fact that when we are taking an x-ray, the plate is in front of the patient. The patient is actually made to put his hand on the hips, bring his shoulders a little forward, and there's this x-ray machine behind the patient which shoots the x-ray beams, and there's a plate in front of the patient which records that particular x-ray, right? So if the patient is actually standing bang on straight, the x-rays pass very easily through the patient's body, and we get an x-ray which is an optimum x-ray. The problem is sometimes the patient might tilt. And when the patient tilts, the angle at which the x-rays enter the body changes. That also means that the image that you're getting on an X-ray is not a perfect image, and if you don't have a perfect image, you can never get a perfect diagnosis. So knowing for sure that the patient has not rotated himself and was pretty still and pretty straight while taking the X-ray film is important. Now, how will you find that out? It's simple. Check the medial ends of the clavicle on an X-ray. They should be equidistant from the spinous process of the vertebrae, and the spinous process of the vertebrae themselves should be in the midline. They should be arranged vertically in the midline. I will show you how that looks and how a mal-rotated X-ray might look. Second, a part of your mnemonic is I. I is for inspiratory. I hope you know the fact that when we take a chest X-ray, we ask the patient to take a deep breath in, hold while we shoot the X-ray beams at him. How do you know whether your patient's X-ray is an inspiratory or an expiratory X-ray? Pretty damn simple. You start counting the number of ribs from behind anteriorly. If you can find 5 to 6 ribs anteriorly or around 10 ribs posteriorly can be seen very, very clearly, the patient actually has taken an inspiratory X-ray. Another important way by which we know whether the X-ray is inspiratory or expiratory is by looking at the apices of the lungs. In case of an inspiratory X-ray, the apices are very clearly visible. You can actually see the lateral edges of the ribs and also the costophrenic angles. The third part of our mnemonic is P. P is for projection. Now, when I say projection, where are the X-ray beams coming from and where is the X-ray plate? So in a normal scenario, the X-ray beams come from behind the patient, the film is in front of the patient, which means the view is called as a PA view. Another view would be the plate is behind and the X-rays are coming from forward. We call it the AP view. Now, in case of an AP view, remember the fact that in case of PA view, we actually make the patient bring his shoulders forward. So the scapulas move away from the X-ray plate. So the scapulas really don't appear on the X-ray film per se. But in case of an AP view, the scapula can be seen pretty easily. Another important thing that you will notice is in an AP view, the hard shadows are kind of bigger. So that can give you a very important clue to which view your patient has taken his X-ray in. Don't confuse an AP X-ray with cardiomegaly, because that's a commonly made mistake by most medical students and some of the doctors too. So be careful there. And the last part of our mnemonic is E. E is for exposure. That's how much of X-rays have we shot at in our patient's chest. So as you might have realized that sometimes you adjust the camera settings and you overexpose things, everything appears very bright, and sometimes it's the setting of the camera is at a low exposure and everything appears pretty dark. That's exactly what is going to happen if you set your X-ray at a very high exposure or a very low exposure. What I mean by this is, in case of a very low exposure, the entire X-ray film will appear more whitish because there are no enough X-rays to penetrate the chest wall of the patient. And in an overexposed X-ray film, everything will appear blacker. Okay, let's have a few examples of what RIPE actually mean when we are looking at X-rays. Here is an example of a perfect positioned patient. Look at how the spinous processes are in midline and the medial ends of the clavicle are equidistant from these vertically placed spinous processes. Compare this with this next X-ray, where you will notice that the medial ends of the clavicle are not equidistant from the spinous processes. Actually, if you notice, the spinous processes also are not in the midline. They are also tilted, which means the patient had rotated himself a little bit while taking the X-ray. Have a look at this X-ray. The X-ray on the left hand side, you can easily calculate around 10 ribs posteriorly. It means it's an inspiratory X-ray. As compared to the X-ray on the right hand side, where you will notice that the film shows less than 8 ribs posteriorly. So this is technically an expiratory film. Another very important part of our mnemonic RIPE was the PA view and the AP view. The one on the left hand side, this X-ray is PA view. See, there is no shadow of the scapula that can be seen on the lung field, whereas the AP view, represented by the X-ray on the right hand side, you can very clearly make out the shadow of the scapula. And lastly, of course, was the exposure. The central X-ray, as you can see, is normal. The one on the left hand side is underexposed, and the one on the right hand side is an overexposed X-ray film. Once you're done with your RIPE, that's rotation, inspiration or expiratory film, projection and exposure, and you're sure that the X-ray that you have received is a standard X-ray and it does not have any problems with the four main categories that we just described, then you can move on to what you can actually see on an X-ray. The total things that you can see on the X-ray can be divided into five main categories: A, B, C, D, E and F. A is for airway, which includes your trachea, the bifurcation point of trachea called as the Carina, and the two main primary bronchi as they enter into the hilum of the lungs. B is the breathing space, which includes your lungs and the pleura that surround it. C is for the circulatory system, including your heart and the great vessels. D is the diaphragm, and E includes everything else, including things such as the bones, the breast shadows, the soft tissue shadows, and any lines, catheters, electrodes that you might see, pacemakers, that falls into the E, everything else categories. Of course, we are going to discuss each one of them in details. At this point, I want to remind you people of the upcoming session at Pulse Tutorials about diabetes mellitus, which is going to be the #1 killer in the upcoming years. I hope you people have already registered. I am going to leave a link in the description box below of this particular video where you can join me for a 2-Sunday course. This is not a 1 Sunday course, it's a 2-Sunday course, because diabetes, the #1 upcoming killer, cannot be understood in details in 1 Sunday. So this is a 2-Sunday course. You are going to choose one out of the 2 time slots, either 1:30 p.m. or 4:30 p.m. on the form, and by the end of Friday, I will be able to help you guys out with which batch you people can fit into. Moving on with our X-ray topic, let's discuss A, the airway. Remember, as I said, airway includes the trachea, the bronchi, the bifurcation point of the bronchi is called as the carinae, and the 2 main principal bronchus. Let's have a look at the X-ray and try to understand what all features can you diagnose by looking at a chest X-ray, the airway part of it. An airway is basically 3 things put together: trachea, carinae and the bronchi, and of course their entry point into the lungs called as the hilum. The first and the foremost things that you will notice here is whether the trachea is in the midline or has it deviated a little bit. Normally the trachea ends at the level of T4 vertebrae, okay, and then it divides into right primary bronchi and the left primary bronchus. If the trachea is deviated, then there are 2 main possibilities. One, something is pushing the trachea away from it, and second, something is pulling the trachea towards it. What can pull the trachea towards itself? These include diseases such as atelectasis, agenesis of lung, pneumonectomy or pleural fibrosis. These diseases can pull the trachea towards the diseased side. Things that push trachea away from the diseased sides include pneumothorax, pleural effusion and large masses that tend to make the trachea deviate to the opposite side. Apart from this, mediastinal or tracheal masses or the position of the patient, if he has kyphoscoliosis, might give an appearance of a deviated trachea. Do watch out for all these causes. So The next thing that we have to understand is the carinae and the bronchi. The carina is the point at which the trachea bifurcates into two. Now, as you see on the X-ray, the right bronchus is much more shorter, it's much more wider, and it's much more in line with the trachea. The left is much more narrower and it's at an angle to the trachea. So the commonest site at which the foreign body will get impacted is of course the laryngeal inlet, but if it somehow escapes that, expect the foreign body to be lodged on the right bronchus because of this peculiar straight and wider attachment of the right bronchus to the trachea. The next point we focus on is of course the carina. This is a point where the trachea bifurcates into two primary bronchus. In a normal individual, the angle of carina would be around 60 degree plus or minus 10 degree, and the range is said to be around 40 degree to 80 degree. Any more or less angulation should be investigated thoroughly of why would the angle of the carina change. In a good quality X-ray film, the carina is actually seen very, very nicely. And this is also important when we are putting a nasogastric tube. If done properly, the nasogastric tube will perfectly bisect the carina. So that helps us in understanding that our tube has gone into the esophagus and gone right down into the stomach, and the nasogastric tube is not inside the trachea. So that is a good enough indicator. The third part of airway is the HighLow structure. Focus on the X-ray here and you will notice that each hilum is a place where pulmonary blood vessels enter or leave, and the major bronchi of course enter. Each hilum also will have a collection of lymph nodes, but these lymph nodes will not be normally visible. The left hilum is often slightly higher than the right, and this is absolutely normal. But remember, both the hilum should be of approximately the same size. Once we are done with airway, we move on to the next B. B is for breathing space or breathing apparatus, which includes your lung and the pleura. Let's have a look at few examples to highlight what exactly I mean by this. When we examine the chest X-ray, we divide each lung into three different zones: upper 1/3, middle 1/3, lower 1/3. These do not match with the anatomical lobes. Actually speaking, the anatomical lobes which are infected, an easy way to remember this is, since there are only 5 to 6 ribs visible anteriorly, even in an inspiratory film, the upper 2 ribs are the upper 1/3, the third and the fourth ribs cover the middle 1/3, and the fifth and the sixth rib cover the lowermost 1/3. The right lung actually has 3 lobes. The left lung only has 2 lobes, but on an X-ray, both the lungs have 3 zones: the upper 1/3, the middle 1/3, and the lower 1/3. Just like we do during auscultation of lung fields, where we compare both the sides to understand the pathology. Similarly, in a chest X-ray, you compare upper 1/3 of the right with the upper 1/3 of left, middle 1/3 of right with the middle 1/3 of left, and lower 1/3 of right with the lower 1/3 of left. Now, as you look at an X-ray, if you see that there are too many markings, there may be problem. It's called as consolidation. Too much of inflammatory changes, maybe too much of fluid. But if there are too little markings or no markings at all, start thinking about why would that happen. Maybe something like pneumothorax is the etiology behind that. So keep this in mind when you are reading your X-rays too. See, when we look at a normal X-ray, you will notice that the bronchovascular markings, which start at the hilum, go right up till the edge of the lung. And the edge of the lung is really near the thoracic valve, okay? But if you see a gap between them, or the vascular markings or the bronchial markings stop way short, something's wrong with the pleura. So that's how it's diagnosed on an X-ray, okay? Another very important thing is check out for any collection of fluid. It will be called as pleural effusion on an X-ray, but it can be exudate, it can be transudate, it can even be blood, hemothorax, but that cannot be diagnosed on an X-ray. If air has collected inside the pleura, of course, it will be called as pneumothorax. What if air and fluid has collected? Then we will call it hydropneumothorax, right? So keep this in mind when we are seeing a chest X-ray. Whenever you see something collected inside the pleura, do check out for tracheal deviation, because these two features always go hand in hand. Once you are done with B, the breathing, go to C, the cardiac shadows. Observe this X-ray and you will notice that the cardiothoracic ratio, that is the width of the heart divided by the width of the entire thoracic valve, should always be less than 0.5. It means that the heart will occupy less than half of the width of the thoracic cage. This rule only applies to PA view, because as we have already seen, AP view, you will always get cardiac shadow which is big. So see to it that you be sure it's a PA view and not an AP view before you call it a case of cardiomegaly. Then you assess the heart borders. The right atrium will make most of the right heart border. The left ventricle will make up most of the left heart border. If you can't make out the right heart border, think right middle lobe consolidation. And if you can't make out the left heart border, it might be a problem with the lingular lobe. We are done with A, B and C. Move on to D. D is for diaphragm. The right hemidiaphragm is always a little higher as compared to the left hemidiaphragm. This is because on the right side there's liver which is pushing on the diaphragm. On the left side, just below the diaphragm, you will see the fundic gas bubble, which is basically the air that is trapped inside the stomach. So there should be no gas bubble below the diaphragm except for the fundic gas bubble. Any gas under the diaphragm points towards visceral organ rupture. So maybe the stomach or the intestines have a hole through which the air is escaping into the peritoneal cavity. This is a surgical emergency. The next thing that we look out for is the costophrenic angles. They should be very clearly visible. Costophrenic literally means the angle between the rib cage and the diaphragm. Okay, so if this angle is seen, things are fine. If the angles are obliterated, start finding out why. Mostly it's pleural effusion in this cases. Before we move on to everything else that remains to be seen on a chest X-ray, I would like to have a look at a few examples here. The examples will make it clear of how you are supposed to read an X-ray. Okay, so this is the first X-ray I am showing you. Observe how in the X-ray film you notice an opacity in the right upper lobe of the lung. This is a classical case of right upper lobe consolidation, mostly pneumonia. The second X-ray I am showing you is of right middle lobe consolidation. Please note, when I am looking at the X-ray, I am actually using the upper 1/3, middle 1/3, lower 1/3 comparison. But as I am describing the lobes, I am actually using anatomical terminology. So the right middle lobe consolidation appears as a small patch, a whitish patch near the right border of the heart. This is an example of left upper lobe consolidation. And the one on the right hand side is the left lower lobe consolidation. This is a classy example of patchy consolidation. So this might be a case of bronchopneumonia, extensive bronchopneumonia. This is a case of hydrothorax on the left hand side and pneumothorax of the right lung on the right hand side. And this is how a hydropneumothorax would look. Observe the black shadow on the left side of this X-ray and a fluid level, a white fluid level that can be seen at the lower end. You cannot even make out the left costophrenic angle. That's because of the fluid collected here. This is how a miliary tuberculosis looks. The hilar lymph nodes are usually involved in miliary tuberculosis. A heel TB, on the other hand, will give you areas of calcifications. The next set of X-rays that I am showing you, will show cavities in them. Let's have a look at them. The first one is a cavitatory lesion on the left side. You can actually see the air fluid level there. The one on the right upper hand side also has a cavitatory lesion with fluid in it. And the one on the right lower side also shows you a nice beautiful air fluid level cavity present. This is an example of fungal ball. Observe how you can see a white mass within the cavity. So basically I have told you about cavitatory lesions and fungal balls. How do you differentiate between them? It's a pretty simple flowchart. I want you people to please take this down. It's very, very important. The cavitatory lesions of the lungs can be easily divided into three main categories by just checking the contents. If the content is air fluid, we'll call it category 1. If it's air only, category 2. And if it is soft tissue density inside the cavity, then we call it category 3. This is how it will look. An air fluid cavity is a black cavity with a whitish fluid settling down. Air only is a black cavity, whereas an intracavitatory soft tissue density would be a grayish mass inside a blackish cavity. I hope I am making myself very, very clear. The intracavitatory soft tissue density can present in cases of fungal ball, which is very, very common, especially aspergillosis. Hydatids, tumors, blood clots may also present like that. The air fluid level wala cavity, you have to check the surface of the fluid. If the surface is straight, it's an abscess. If the surface is wavy, think hydatid cysts. Which leaves us with air only cavity. The air only cavity, you have to check the thickness of the wall. If the wall is pretty damn thick, it can either be chronic abscess, in which case the wall will be regularly thick, and if the wall is irregularly thick, start thinking about tumor breakdown. If the wall is thin, then our differentials will include stuff such as pneumatocele or bulle, depending on the site. So a central thin walled air filled cavity, you call it a pneumatocele, and a peripheral or a subpleural air filled thin walled cavity will be called as a bulla. Now once you're done with A, airway, B, breathing spaces, C, the cardiac shadows, and D, that's the diaphragm, then is the time to go to everything else on the chest X-ray. Everything else will include mediastinal shadow, the bones, the soft tissues, any tubes or valves or drains that you might notice on your patient's chest X-ray. These are a few examples of how things may look on a chest X-ray. Here's an endotracheal tube, an ECG cable. You can see a nasogastric tube in this particular X-ray here. Check out the presence of central line that you can see as a small white line starting at the jugular vein level at the neck. This is how a pacemaker looks on a chest X-ray, and this is how an intercostal drain appears. I hope this webinar has been helpful to you guys. This is a primer course. Please understand this is not everything, but this is a system. And if you follow the system, trust me, you can never make a mistake. So trust the system, follow the system, and the more you repeat this particular system and the more X-rays you see, the better you will get at reading an X-ray. I hope to see you in my next session of diabetes mellitus on Sunday. The link for the form is given in the description box below. Please fill that form. The fees mentioned on the form is for 2 Sunday course. It's not a single Sunday fee, but what you get in return is this fantastic plan of how you can manage your patients in a much better manner. And please remember, diabetes is going to be the #1 problem that you people and your patients are of course going to face. So the more earlier you know about it, the more ahead of other doctors you guys will be. I'll see you in my classes on the upcoming Sunday. Till then, take care, keep studying, keep learning, keep rocking. This is Dr. Avinash signing off. See ya.